Welcome everybody. My name is Eric Burning. I am the president of the board of directors for ASAP. I want to welcome everybody in tonight. Thank you for joining us. Tonight we got Dr. Brian Dlouhy with us, and he will be presenting information for us to learn from and then to interact with. So I'm going to turn over to Dr. Dlouhy. If you could take it away.
Thanks, Eric. Thanks for hosting this Zoom conference presentation tonight. And thanks, Patrice, as well. My name is Brian Dlouhy. I'm a pediatric and adult neurosurgeon here at the University of Iowa. And I have a clinical focus in Chiari and in kids, adults, and the complex kind of bony and ligament abnormalities that can occur with Chiari as well. Let me get my presentation loaded up here. All right, so I've given lots of different presentations on Chiari, and I try to add different cases and different presentations of cases I might have done recently or new things I haven't talked about, because I can't talk about everything, I've realized now in a short time. But I'm going to try to go over the main focus, start from the beginning, because there's going to be people that know a lot more about Chiari than others that do. Okay, but we're going to start from the beginning here. Okay, I do want to talk about the conference that we're hosting here in Iowa City. I'm hosting this, and we've invited all the experts in Chiari, Syrinx, EDS, tethered cord, to Iowa City in Iowa for the ASAP conference. It's an annual conference held every single year in different locations. This is July 21st to 24th. And it's here, it's a lot of fun. It's a great time to interact with a lot of physicians and clinicians, and to hear high-level presentations, interact with other people, understand that there is hope for your condition that's out there, okay? Understand what other people have gone through, and what they're doing now. So put a plug out there for that. And now I'll kind of get into this talk. So, what is, we're looking at a brain MRI here. We're going to talk about this first, and we're going to talk about what is a Chiari malformation. What I'm showing you here is, this is a normal looking cerebellum, okay? This is where it's supposed to be positioned. That the red outline is over the cerebellum. The dotted line is the opening of where the skull kind of meets the spinal canal. And so you see all that black there, that's fluid, that's CSF, it's surrounding the cerebellum. There's no compression of the brainstem. I'm going to contrast that with the Chiari malformation. So this is a patient of mine, and this is, I'd say, a more severe type of Chiari malformation. You can see here, I've kind of zoomed in on the right there. You see the cerebellum. There's a lot of, it's going over that dotted line now. It seems very compressed. There's none of that black space. The brainstem is being compressed. It's being pushed down into the spinal canal itself. And this can lead, and this is what we think of a Chiari malformation. And what we think of really someone that's going to probably be, have symptoms of a Chiari malformation. So by radiological criteria, this meets it. It's more than 5 millimeters below the opening of the skull. But more importantly, what you see here is the compression of the brainstem, blockage of the CSF flow. And that's really the biggest thing. When you look at these things, that's what you're looking for. You're looking for really blockage of CSF flow, brainstem compression, and really kind of other abnormalities as well. So quick overview, Chiari malformation. It's a congenital developmental abnormality. We think it occurs in about 2 to 4% of the population. It's really not thought to be an abnormality of the cerebellum. It's really thought to be a bony problem and really an intradural scarring problem. So there's not enough space in the posterior fossa in the back part of the skull where it holds the cerebellum, and there's scarring intradurally, not in everybody, okay, but in some people. Occurs before 5 years of age, minimal changes that occur over a course of a life. There can be changes, but usually when it kind of occurs, can it get better? It can get a little bit better as maybe a child gets older. It also can get a little bit worse, but you're not going to see huge differences, unlike different than acquired Chiari malformation, which we'll talk about. Patients can present. I've treated patients from babies all the way to 70 years of old. That's, I think, the oldest surgical patient I've treated. And symptoms are extremely varied. Most common is really a headache. So really, when people think of a Chiari, they say, why did I get this? What caused this? Oftentimes a big reason, and for everyone, it's a little bit different. Okay, it's kind of very heterogeneous condition. It means a lot of different causes for it. But a big cause that you'll see is just a decrease in the size, like I said, of the back part of the skull. That's what you're looking at here. You can see the crowding around the cerebellum there, the lack of that the fluid, the black CSF spaces. That's a 14-year-old girl on the left. One of my patients, a 37-year-old woman, another patient on the right, okay? Both of these are very crowded. You can see the brainstem is compressed really in both of these. And these are both kind of pretty significant Chiari malformations. Other cases, the posterior fossa really is not that small, okay? And I'm showing this is another example of mine. And this is this kind of spacious fluid above the cerebellum. That's what I'm showing there in that yellow arrow. Again, that dotted line is the opening of the skull. Chiari malformation is where it descends below that by more than 5 millimeters. That's the kind of radiographic definition. You can see the brainstem is also compressed here. What you have to ask yourself is, if it's just a small posterior fossa, if it's a small space, then why is there all this fluid above there? How come the cerebellum doesn't just want to sit up there? Why is it going down further? And there's a lot of different reasons for that. And this may be where one of these, the problems here is there's intradural scarring problem. There's scarring inside, and fluid wants to get by, wants to go out through this channel here, and it can't. And so it gets blocked by the scarring inside, and it keeps pushing the cerebellum down. That happens in development. And this is one of our cases. This is showing the Chiari malformation, showing the brainstem here. You can see how big the fourth ventricle here is. That's the area. You can see my arrow. And this dotted line is the opening of the skull. Fluid can't get out of this fourth ventricle, and that's because it's trapped by this arachnoid adhesion over the opening of the fourth ventricle. And this is from a microscope. This is the back part. You're looking back at an intraoperative image. This is the brainstem. This is the cerebellum up here. We've divided this two, and we're looking this way. And you can see this, we're cutting this, opening this membrane up. And that's what allows the CSF to flow. We've published a lot on this intradural scarring problem as one of the mechanisms for causing, for a part of the pathophysiology or the problems in Chiari malformation. You'll see this is the opening of the dura here. You can see that the arachnoid, this is the covering of the cerebellum, is very opaque. It's whitish, and that's part of the scarring. This scarring, why does it occur? We don't know. It may be from in utero. This is, again, a congenital developmental abnormality that could be trauma at time of birth, or just minimal trauma that is not even aware. Child's born fine, but the head is squeezed through the birth canal. That may cause a little bit of bleeding, and in some people, they just have more of a reaction to that blood, or the blood pools in a certain location that causes the scarring. We've seen these adhesions that also occur between the cerebellum and the brainstem. That also is a problem. Part of the pathophysiology and mechanism of Chiari. There's veins that obstruct the CSF flow inside. So all of those things kind of contribute to the Chiari malformation. This is an example of a 2-year-old, and this is showing what happens over time. So it's 2-year-old there on the left. That's an MRI, and below that's a CT scan. You can see what happens when the child gets to 4 years old, which is on the right there. And what happens is the bone gets thicker. You see that on the CT scan, that this area gets smaller. The cerebellum grows a little bit more. There's less of this white space now. And there's less room then for the cerebellum. So where can it go? It has got to go through the spinal canal. And then what it starts developing here is a syrinx. So these are rare cases, but we have a couple of these where you can see the development of a Chiari malformation over time in a child. And this is one of the mechanisms, right? You're seeing just a growth of the bone and a decrease in the size of the back part of the brain. We know that Chiari is a big mechanism for causing syrinx. That's the fluid cavity in the spinal cord. That can lead to scoliosis. You'll see this in children and teenagers. And, and Syringomyelia is pretty common in a lot of the surgical cases of Chiari, because that's one of the main reasons why we do surgery for Chiari and syrinx. Is if they have for Chiari is if they have a syrinx, and then they can get scoliosis, which then can lead to additional surgery to correct this scoliosis, having a spinal fusion. So this is a syrinx here. I'm showing an example from an MRI, and this is the scoliosis on an X-ray showing the curvature of the spine. What's interesting about the Chiari and the syrinx is that one may have similar imaging findings. So here's a Chiari and syrinx. It looks almost identical to this Chiari. This does not have a syrinx. So why that happens, it's a little bit complex. It's probably in some patients, they have a more persistent central canal within their spinal cord. And that allows a potential space to form. In CSF, they can enter that persistent central canal, and that can lead into a dilation of the spinal cord. We've kind of published on this intradural pathology seems more common in cases with syrinx. This is Chiari with syrinx. We saw this intradural pathology, the scarring problem in 60% in patients without a syrinx, which is Chiari in 1/3 of patients. We think this is one of the then a big driver is this occlusion over the fourth ventricle of leading to a syrinx, at least one of them. And you'll hear a lot about this. This is in the coming years from other studies that will come out. A randomized trial done by the Park Reeves that looked at what was it better in cases of syrinx in children? Was it better to open the dura or not open the dura? And I think that there's a lot of explanations for syrinx, but a lot of people will still advocate maybe for one surgery or the other. But I think a lot of the evidence points if someone has a syrinx, unless there's some extreme circumstances or unique circumstances, they should probably have the dura opened. Okay, and so I just showed here a video showing us opening that veil over the fourth ventricle, and then you can see immediately CSF starts flowing out normally. And this is a big part of a case like this. I've done other cases where maybe someone has not opened the dura and they have a very large syrinx, and that syrinx persists. I'll go back and I open the dura, and they have a veil like this, and their syrinx then reduces. So it's really a lot of cases like that prove that opening the dura and taking out these adhesions is something that's really a part of the curative strategy for treating syrinx. I think I titled this talk, what's the treatment now in 2025? I think a big thing is going to be more and more evidence that suggests that patients with syrinx are going to do better with having the dura opened. Now, I think there is more complications when you open the dura, right? But if you can limit those complications, then opening the dura is probably better. So, what are other causes of tonsillar herniation? So that's where the cerebellum goes down through the opening of the skull into the spinal canal. Something called acquired Chiari malformation type 1. And this is not your congenital cases. These are cases where someone may have a hydrocephalus, increased intracranial pressure. They may have a tumor in the brain, and they may have a CSF leak, right? So then they have a CSF leak in the spinal canal that's then pulling CSF out of the brain, and it basically pulls the cerebellum and the brainstem and the rest of the brain down through that canal. So someone with hydrocephalus, that can be this, or they can just have idiopathic increased intracranial pressure. You can see the tonsils hang down there below. They look very similar to Chiari malformation, but this is treated with a shunt or an ETV, which you can see here, and then that completely resolves what looks like a Chiari malformation. The ventricles are small, the brainstem comes up. Okay, the same thing you can see with the CSF leak. If you treat the CSF leak, you'll see the tonsils rise up, and that can essentially treat someone with acquired Chiari malformation or acquired tonsillar herniation. So I just want to touch on that. It's a big topic, and that'll be a topic that we'll be discussing at the conference and here in IOC for the ASAP conference. Symptoms of Chiari malformation, most common symptoms you're going to see, is Valsalva-induced headaches. These are headaches with coughing, laughing, straining, and they occur usually in the back part of the head, so they're occipital in nature. That's not always the case. I feel like that patients that are maybe older, so these are adults, maybe 20 or 30, they got out of the kid range, so out of the pediatric range, and they come in with a syrinx, and that syrinx is large. They oftentimes won't have a headache. It's as if the syrinx is a relief valve for the pressure. And so then they'll come in with more symptoms of a syrinx symptoms than they will of having those kind of headaches. And maybe that sometimes those patients present at a later time than patients' headaches, because headaches can be quite disabling, these types of headaches. The other common symptoms then are swallowing difficulty, choking, aspiration dysphagia. That's usually from the cerebellum pushing and the herniation pushing on the brainstem. You can get dysarthria or signs of this is from an absent gag reflex. That can often be that they cannot really feel the back of their throat. That can lead to swallowing difficulty or choking. Also, this compression on the brainstem can lead to sleep apnea, obstructive or central sleep apnea, and snoring. The spinal cord dysfunction, Syringomyelia, that's the syrinx. They can get, again, the scoliosis. You see that in kids mostly. It's not going to happen in adults. Motor weakness, sensory changes, even spasticity if it goes on long enough. I typically think that symptoms of Chiari malformation differ by age. The literature kind of shows this as well. Very young children, they have a hard time expressing themselves. They may just fail to thrive, swallowing difficulty, they can't gain as much weight. Children that may not complain about a headache, they may have a difficulty expressing that headache. That may lead to constipation, abdominal pain, because they don't want to bear down and produce a Valsalva maneuver while they're trying to go to the bathroom, right, when they're on the toilet. So it can be difficult. Kids may grab the back of their head. They may grab their head. They may just scream. They may do some arching. I've seen other kids do arching and movements of their neck that go back. Or when they pull their head back or they move their head, they will scream in pain because that changes the position of the tonsils. That may obstruct more CSF flow. So those are all situations that I've seen. There's many others, but young kids that can happen.
Great.
The suboccipital headache I talked about before. Again, back part of the head. I can, most patients, I point to exactly where in their head where I think it's probably occurring. Is it occurring right here? It's usually right below that bony protuberance that occurs in the back of their head. It's almost going down into the neck, right? And so then the pain can spread to the front of their head. It can go down the neck. Those are quite common. Sometimes the headaches don't have to be occipital. They can still be Valsalva induced, and they can be more in the front just because they radiate to the front and they just may not feel the back as much. But any of these maneuvers, coughing, sneezing, laughing, crying, straining, you'll see this in kids a lot more. It's just exertion, right? Outside playing, they'll get headaches. So the signs of a Chiari malformation, usually when I were doing an exam, the biggest key things are like an impaired gag response. It's really, really sensitive. So lack of sensation in the back of the throat and just a lack of a typical gag response that you would see, in someone that's either, 5 years old, 10 years old, 20, 30, 40, 50, right? So some can get like a loss in the facial sensation, which are from cranial nerve dysfunction, hoarseness, and the Syringomyelia associated findings usually increase or decrease reflex. You can have either. Again, this scoliosis, which is more atypical, and curvature, not like the typical scoliosis. Sometimes the scoliosis will occur much younger, so juvenile scoliosis, not like your adolescent scoliosis, not like the teenager associated scoliosis, and that'll have a typical curve to it. So this will be a different type of curve. And you get weakness, atrophy of the arms or hands, decreased sensation to light touch or pinprick. These are all signs that we see. I have in my clinic, because I recently saw this, I've had patients come in, think they have a Chiari, they'll have maybe some tonsil herniation, and they're coming to me but they're not a typical Chiari malformation patient. You can see that right away. And I do a clinical exam, I get the history, and I'm pretty convinced they don't have the symptoms of a Chiari malformation. They get testing and they'll have symptoms of ALS, which is amyotrophic lateral sclerosis, or Lou Gehrig's disease, which is a devastating condition. So they get treated by neurology very quickly for that condition. I've had patients come to me and say that someone else has told them they have ALS and Lou Gehrig's disease. And I say, no, you don't. You have a Chiari malformation, and you have a Syrinx, and that's what the problem is. And that's what they have. The clinical exam, the history and the clinical exam is extraordinarily important to be able to distinguish what, Chiari, because it is quite common, 2 to 4% of the population. So a lot of people will have this, but determining whether it's clinically significant or it's to be treated as a Chiari or from some other condition is very, very important. So you might ask, if this occurs in development, why does it take some people so long to develop symptoms? Well, it's really still unclear. Some symptoms, I think, are just very subtle. They may not be noticed by the patient, right? They just, they go through their life and say, oh, I got this, I have that, and that's very common, especially in adults. They think, oh, I have some numbness here at this, and it just doesn't bother them that much, so they ignore it. And eventually things get worse, and so maybe they get imaging, or they get in an accident, and that leads to imaging, and then and then it gets found. Also, Chiari is somewhat dynamic, right? So tonsil herniation can be worsened by weight gain or Valsalva maneuvers, what you're doing in life, weightlifting, jobs that require lifting, etc. So those are all factors a little bit. And even though the tonsil herniation may not change a whole lot, like I mentioned, some of these things can make the image look just a little bit worse, like there's more crowding, there's more compression. And so that measurement may stay the same, but what it looks like on imaging is just more crowding and more obstruction of CSF flow. Okay. So again, the treatment for Chiari malformation, observation, surgery, you can do obviously medical lifestyle management. For someone that really has a true Chiari malformation and they're pretty symptomatic, surgery is really the answer. There are patients that have, really, I know they're symptomatic from a Chiari malformation. They may have minimal headache. They just get a headache once in a while. Valsalva maneuver, it's not bad. I give them the option if they want to have surgery or not. I go over the risks and the benefits, etc. I would say many of them, since it's not bad, they say, no, I'll just watch this. And I would say most of those patients have not come back to have surgery. So it just depends on the severity of symptoms. Surgical treatment, what do we do in surgery? Kind of switched some images before of kind of explaining what causes the Chiari malformation and the intradural scarring, or the small back part of the brain, the back part of the skull, this housing the cerebellum in the brain there. And that's one of it. It's making one part of the surgery is making that back part of the skull bigger for the brain. So we make a small bony removal, and there's a tight band there that we remove as well that kind of allows the dura to come out and gives more room for the cerebellum. And like I said before, if there's a syrinx or the tonsil herniation is severe and there's brain stem compression, oftentimes, we open up the covering of the brain, the dura, decompress internally, remove the scar tissue, open up all this CSF pathways, and expand the dura with a graft of tissue from the same patient, from the patient there that's you're operating on, right? Not like some other cadaver tissue or something like that. So, this is an old slide. This is from showing our data from 2003 to 2016. We did 388 Chiari surgery. That is up, I think, in the last 9 years to around 700 or 800 patients. But we've shown many different publications, written up our series of surgical treatments and outcomes and such. You can look at that in the literature if you want. I'm going to just kind of briefly describe the surgical technique that I use. We use a linear incision when we take off this bone here in the back part. It's a small opening. We take off part or all of C1 in the back part of the skull. We do a linear incision for the dural opening. We intradurally decompress everything, and then we use the patient's own tissue from the same incision. So it's actually this tissue here. It's called the fascia, and it's an excellent tissue. And it's really limited our CSF leaks over the years. I think those 800 patients who only had two CSF leaks. So those were back in 2006. So it's an excellent tissue because it's your own tissue. It's highly vascularized. So once we sew that in, it gets vascularized very quickly. So it just seals off very quickly. It's not going to cause a reaction by the patient themselves. It's also very expansile, so it allows a lot of room for the cerebellum. This is showing kind of as an example. This is the back part of the cerebellum here, the opening of the dura there. Again, in suturing this patch, and this is what this looks like in the end. This patch, giving more room for the cerebellum to sit. And this is what it looks like from MRI, from a pre-op to post-op image, and you see the cerebellum sitting here, and this is what it should look like post-op. Okay, not every case is going to look like this. Every Chiari is so different, right? This is ideal. This looks normal. Okay, this is the same patient. This is their syrinx completely gone here. This is a child, I think, around maybe 12 years old, 14 years old. And there's no more brainstem compression. You see that's gone. So that's not always possible. Sometimes the herniation is quite severe. It can be down to here. And then there's no way you're going to you can't remove the goal is not to remove all the tissue here. That will lead to instability, which we'll talk about in a second. So who's a candidate for surgery, really? Valsalva-induced headache. Again, radiological appearance of obstruction of CSF flow and neurological findings. Okay. So I'm going to move on to this other topic. Which patients with Chiari need a fusion? Posterior fossa decompression is effective at treating Chiari. However, I talked about that previously. Some patients with Chiari have these bony and ligament abnormalities where the skull meets the spine. Okay, these are congenital and acquired. This can lead to compression of the brainstem from in front and pushes the cerebellum back and then down, causing the Chiari malformation. Can lead to instability and then misalignment of the bones, which also will cause a decrease in the posterior fossa and the skull. And when we're talking about a fusion, at least in the patients that I treat and the ones that I think need a fusion, it's not just they're getting a fusion. Really, patients need realignment into their normal bony position of these abnormalities, and then the fusion is really to maintain that normal alignment, right? And that abnormal alignment can be part of the pain and the issues that they're having in their headaches in terms of also their neck. So fusing them in a more normal alignment is critical, right, for them to have relief of that. So, the very first fusion associated with Chiari malformation occurred at Iowa, at the University of Iowa here by my mentor, who we're going to honor at the ASAP conference in 2025. He's been retired for many years now from operating, but this is done in the 1980s. It's not a new approach, so it's been around for 40 some years. Okay. And we've published many brainstem studying this over time. And this is just kind of one example. You can see how it's an old image here, but this brainstem is being pushed back and the cerebellum is being pushed back by the bone in front. So where the skull meets the spine is called the craniovertebral junction, or the CVJ. And that's where you have this occipital bone. Again, the cerebellum sits back here. And you have C1 and C2, and this is part of the spine. Okay, so this is the front, this is a side view. Cerebellum sits back here, and there can be bony abnormalities that occur in all of these different bones. The occipital bone, C1 or C2, and that can lead to instability problems. You can also have problems in the ligaments. What's so amazing about this part of the spine and where the skull meets the spine is that many of these joints are very flat, and that flat joint orientation allows us to move our neck in all different directions. The rest of the spine helps as well, but this is the major area, right? This is about 40% of our rotation of our head back and forth like this. It's also about 40% of our flexion extension. Okay, and to do that, it's because these joints here are very flat. Well, what holds them together are many of these ligaments. So that's where these patients that have EDS or Ehlers-Danlos syndrome or some kind of hypermobility where their ligaments are much more lax, that can lead to kind of more movement of these joints, and that can lead to problems and instability. So there are many different congenital and acquired abnormalities associated with Chiari. There's a whole long list here. I'm not going to get into any of this, but my point is to say, if you have a Chiari malformation, you need to rule out, that you have any of these other bony abnormalities. Sometimes it's not easy to see that on MRI, and people can get a little fooled by what the MRI looks like, and they may have something that's a bony abnormality. They just don't realize it. Okay, so we know that by getting a CT scan. If we see something a little bit abnormal on the MRI, that can help in treatment going forward. So you can see these are all Chiari malformations. These are all bony ligament pathology and abnormalities associated with Chiari. Okay, and you can see the compression of the brainstem in many of these cases from in front. Okay, and that's a big part of the problem because we'll have a lot of brainstem symptoms plus the Chiari symptoms. And just doing a treatment, like I said before, the standard Chiari treatment can potentially just make these cases worse. Because now there's just more room to push the brainstem back, and that can lead to really some acute symptoms. So that's why it's so critical to make sure when you treat some of these patients, you're not just doing a standard Chiari decompression, but you're doing the fusion surgery as well and realigning the spine, taking away that compression from it. So I'm just going to throw out the most common bony abnormalities that you'll see with Chiari. And that is, one is atlas assimilation. That's where C1 is fused to the skull. The other ones are something called a clipal file abnormality. Okay, and that's where you have these additional bony abnormalities up and down the spine. And the other one is a shortened skull base clivus, and where the part of the skull, they're called the condyles. Okay, that's where they sit on C1. That's called chondral hypoplasia. And that's where those are a little bit smaller. These little protuberances are a little bit smaller than normal. And that allows them to move a lot more. And that causes instability. We've developed these treatment strategies over many years. I'm not going to kind of go over all this, but these are very, very complex and a lot of different images that we get before surgery to kind of determine, if you have a Chiari and it's not a typical Chiari, right? You have these bony and ligament abnormalities. We get an MRI. We get an MRI with a flexion extension of the neck. Okay. We get a CT scan. Sometimes we'll get a CT scan with an angiogram associated with it, which is a vascular study, to look at the vessels as well. And I'll get x-rays of the neck while someone's staying upright, a flexion extension, because that allows gravity to see what does it look like, the bones, right, when you're upright. And is there in the alignment and of the bones in that way. This is kind of the latest algorithm that we've created for these bony abnormalities and Chiari malformation. So here they are, MRI of the brain and spine. Again, a flexion extension MRI is absolutely critical. A CT with 3D reconstruction where the skull meets the spine, cervical neck x-rays, those are all critical. So what do? We try to realign the spine. There's all different ways we can talk about this. We published this technique. This is the technique kind of settled on now over many years, and I've really done this so many times, sort of perfected this. And that is a couple of different things. So patients come to the operating room. We have this intraoperative CT scan, and that is really, really a game changer. That allows you to really see how the bones have changed now when you put someone in traction in the operating room. This is when they're under anesthesia and completely pharmacologically, so using drugs to paralyze them. So then the muscles they're no longer fighting you, and you can really change the position of the spine in a way that's really, really unable to do any other way. Intraoperatively, we can use instrumentation and tools then to distract the spine and move the spine around. All this is done while we're seeing electrical signals through the brain down in the spinal cord to make sure that those signals are still intact. And that gives me a lot of information as a surgeon. And we use x-ray at the same time as we're manipulating the spine to say, how do things look? And are they aligning like they should? So this is another teenage girl with clipal file, a lot of problems. And it's a challenging case, but you can see the brainstem very compressed here. There's a Chiari malformation, tonsils kind of cerebellum come down, brainstem's being pushed down from in front and in back. This is the bone that goes up, and this is post-op, right? This is after all those maneuvers I just talked about. So we push this bone down and in front where it's supposed to go, and that's what you see here on the CT scan. And we kept it there by doing a fusion. And we fused the skull to the second bone, okay? And that's what you see here, this intraoperative images, and I think you should be able to see what here, yeah. So this is the maneuvers I'm doing. Part of the maneuvers is I'm distracting, so you can see this little motion here of the spine, and that really gives you a huge benefit. It's not much. All you need is like a centimeter or half a centimeter of movement here, and you're really pushing this bone down. And that's what gives you such an improved radiographic outcome here on the right compared to what you see here on the left. This child did fantastic. All our symptoms resolved, which are a lot of brainstem dysfunction symptoms, swallowing problems, and hoarseness, and weakness, and such. So we've treated many of these patients. I think it's many more than that now than 109 patients over the years, but many of these patients improve. I like doing these surgeries because they have such improvement, because there's such a radiographic evidence of problem that you're alleviating all that problem when you're done. And so they often do very, very well. There's another kid, a 16-year-old boy. Again, this had all brainstem symptoms, mostly nystagmus, had no headaches really. Hiccups, balance problems, swallowing difficulty, sleep apnea, and weakness. You can see this compression in front from the bone, and this compression behind is pushing the brainstem down and the cerebellum down. It's again a very severe Chiari malformation, a little bit of a syrinx in the spinal cord. And this patient has not just Chiari malformation, but all these other bony abnormalities. Atlas assimilation. I'm not going to go over basilar invagination. I'm not going to go over all of this. This for sake of time, and I want to answer people's questions. But the key here is you got to get a CT scan. You got to get a flex X MRI. If you're not getting that, then we're just not doing the complete workup for these kind of patients. This here is just a lot of detail. And this is the treatment strategy that we use. Again, that O-arm, this intraoperative CT scanner, which is absolutely critical for this kind of these kind of patients. This is the X-rays, and after we've done the CT scan and put them in traction and realign the spine, how we want to before we actually open the patient. This is our ultrasound. Things look good, but they didn't look good enough, so we open the dura. Use our patch, fuse everything, use the patient's own rib for fusion, use the patient's own fascia. So everything is the own patient. You can't reject any of this tissue. And that's what leads to a lot of success. Use all those tools I mentioned. And this is what you're going to get in the end, right? Is a much, much better picture. So we've moved that bone down and in front. I've taken away the compression from in front of the brainstem. The brainstem is no longer just a little hourglass here. It's normal in size as it goes down. There's a lot of CSF around the cerebellum, like you see here. There's a lot more room. See how small this back part of the cerebellum is here, right? And now how much bigger it is here. So that's what we want to see. This is a great radiographic outcome. This patient also had an incredible clinical outcome as well. So all the symptoms essentially resolved. So 5-year-old boy, again, same problem. You see this compression from in front. Again, we realigned the whole spine. You can see here this patient, we didn't have to open the cover in the brain in this patient. So just decompression from the extradural decompression, which is not opening the cover in the brains because the ultrasound looks so good, and then we had such a great realignment of the spine. That was his major problem, right? So not really intradural scarring problem. So we didn't have to open. He did fantastic. This 9-year-old girl, this is her and her brother both had Chiari malformation and hypermobility and these bony abnormalities. The brother was treated somewhere else, had a lot of problems, complications. So he saw me, and then I saw the sister as well. The sister not had surgery yet. You see all this black around here. This is a scar tissue that's trying to form to stabilize this joint. This is unstable child. This girl had a huge syrinx. And we realigned the spine. You see that here. Fused this child. We'd open the dura and stabilize the spine by doing the fusion, and the syrinx completely resolved. So not every patient that has all these bony abnormalities need a fusion. It just depends on images and how things look. So this woman does have all this chondral hypoplasia, this kind of shortened clivus, so smaller, joints and such. Would have vascular invagination, but doesn't really have the brainstem compression that you see from the other cases. A lot of fluid still around the brainstem from in front. Has a very large syrinx, and her main symptoms are all just syrinx related, not brainstem at all. This patient had only the extradural decompression, which is just removing the outer covering of the dura. You didn't have to open the covering of the dura here. Now, I mentioned before, I almost always open the covering of the dura. There's some rare cases, right, that we just haven't done it because it just looks so good from the ultrasound at the time of surgery when we take off all the bone, do the extradural decompression that you say, well, geez, I mean, CSF is flowing so normally, it'd be hard to imagine that the syrinx isn't going to go down yet. But these are really unique, these cases do work, and but they're not our typical strategy. So summary, which patients need a fusion? These congenital bony and ligament abnormalities and instability, lead to instability, brainstem compression from in front. Some I haven't gone into this, but there's some other failed cases where they have poor dura ligament muscle closure during previous Chiari surgery, pseudomeningeal or weakened neck musculature that can lead to it. I've had other, but those cases don't always have to have a fusion. It just depends on the patient. Just depends on the patient and what the imaging looks like. So this can lead to misalignment where the skull meets the spine. They can have progressive kyphosis, instability, brainstem compression from in front, and that would require a fusion type surgery. So I think it ended just on time here to answer questions. This is from Andrea Doman. After having the decompression and dura opening and having C1 and C2 shaved, is it safe to get your hair washed in a hair salon sink? Yeah, so from all my patients, it depends on the surgeon, right? They're all going to change and have different opinion on things. But, I always have the sutures come out at 2 weeks. At that point, there's still some healing that's going on. Okay. And I usually say no, washing, no, like this hair salon for at least 3 weeks. So no like bath or soaking your incision underwater, going to a pool or ocean or lake for 3 weeks. After 3 weeks after surgery, you can do that. That's pretty reasonable. I've never had any kind of complications by doing that. Same thing for getting your hair dyed, etc. Next question is from Gadwiri Mwiti. Do you recommend specialized neurological physical therapy post-op to regain gait balance after shunt surgery, and how long does healing take to optimal health on average? Yeah, so it depends on why you're getting your shunt. But we're getting the shunt for IIH, so idiopathic intracranial hypertension or hydrocephalus. Many of those patients obviously will have gait problems. The shunt's it's going to help relieve like those acute symptoms that you might have, headaches, maybe some acute balance problems, but some of the problems from hydrocephalus or that increased pressure, they're still going to persist. And there may be some damage from it. Same thing for Chiari. So patients may need some physical therapy to help get improvement from strength or balance. That's probably just true for most shunt surgeries and true for Chiari. How long does healing take to optimal health on average? Honestly, I'd say after any kind of event like this, usually we talk like a year to see like your final state of recovery after a Chiari shunt surgery, any kind of thing related to the brain. We usually give that a whole year. It may happen faster than that, but we give it up to a year to see improvement and change because the brain is so plastic and is able to adapt so well. All right, Nikki Gupton says, do you recommend keeping a 5-pound weight limit after decompression? Do you recommend surgery again if symptoms come back? Yeah, everyone's gonna be a little different. I have and I'll explain why would you have a weight limit after a surgery like this? There's a lot of weight restrictions, right? In terms of lifting weights after surgery. Rest of the body, you're using your muscles. They don't want you to use that muscle, so they'll wait till it heals. It might take 6 weeks. One thing is this surgery that occurs in the back of the neck is you dissect some of these you're dissecting neck muscles off, right? The skull, and from the spine. I just talked about how important those muscles were for stabilizing this part of the spine, because this part of the spine, or the scoliosis spine, does not have the normal spinal aligned arrangement. The joints are different. They're flatter, right? So you rely on these muscles and these ligaments to hold it and keep it stable. So, and the problem is if you go do activities, this is an area in the back of the neck where if you do swimming, if you're doing this in front, if you're doing any kind of weightlifting, you're picking things up, you're going to pull those muscles. And all those stitches that were used by the surgeon try to pull the muscle together, and that's critical, is going to stretch, pull apart. And you might have some hypermobility. You're more likely to have more elasticity to your tissue. It's going to be more likely to tear. And so what I do is, for my patients, I have a kind of 10-pound lifting restriction for the first month. And then after the first month, I just keep it easy for them to remember and receive. In the second month, then you do 20 pounds. Third month, 30 pounds. Fourth month, 40 pounds. Fifth month, 50 pounds. And that seems to help. The one thing I do tell people is I say, you know, if a 10-pound lifting restriction or a 20-pound lifting restriction does not mean you go to the gym and lift 20 pounds and you can do 20 reps. I did have one patient do that, and their scar widened, some of the most I've ever seen. So that's an issue, but that's how I do it. Let's see. All right, good bunch here. Let's see. All right. I have a Syrinx thoracic T5 to T9, and it went from 8 millimeters to 5 centimeters in 2 years. Lots of symptoms like numb right hand and feet, chronic neck pain, headaches, nausea, vomiting, etc. What kind of doctor should I see? That's from Kristen Emsley. Well, Syrinx are mostly seen by neurosurgeons. It depends on what the Syrinx, what's causing the Syrinx. And there's lots of different causes of Syrinx. It could be idiopathic. It could be traumatic. It could be from a Chiari. It could be from a tethered cord. It could be from a tumor. So those things that we worked up, and most of the times you'll see a neurosurgeon for that, right? So they'll refer you to a neurosurgeon, and they'll be able to figure out, you know, what to do. Let's see what else. From Delia Vickers, I had a decompression in 2002. Since then, some of my symptoms have increased over time. Neck feels unstable. What would you recommend? So, you know, we talk about doing surgery. Can symptoms come back? They can. Can the Chiari come back? It just depends on, everyone's a little bit different, right? So, if you have some symptoms, I would get another MRI. So similar symptoms, get another MRI of the brain and cervical spine. If you had a Syrinx before, I get a thoracic MRI as well, or a lumbar spine MRI in addition. And if that shows something, right, that's concerning for recurrent Chiari malformation or recurrent Chiari type compression or obstruction of CSF flow, maybe you need a Chiari decompression. If there's other things that look like there could be other bony abnormalities or ligament problems there, then you have other signs or symptoms on exam, you may be hypermobility, then you may need to get a more dynamic image like an MRI with flexion extension or a CT scan to look at those bony abnormalities. Jennifer DeBabo, I'm 69, I had a decompression 25 years ago along with dissection of a grapefruit-sized arachnoid cyst. Okay, I do pretty wonderful. I have my bad days, but for the most part, I'm good. What does my older years look like in your opinion? Do you foresee any changes if I've been stable for all those years? Yeah, I usually say when patients have been stable like that, and I've treated same thing, done an arachnoid cyst plus a Chiari decompression, same surgery, and those are very satisfying surgeries because patients do very well because the arachnoid cyst will oftentimes go away, the Chiari will improve, usually by that point, you know, the CSF flow is flowing normally. You know, you're probably not going to have many symptoms. You're probably not going to have surgery again. So Kristen, yeah, comment, I think trauma for that Syrinx. Yeah, it depends how severe the trauma is, and, you know, a neurosurgeon will be able to better answer that. The images would probably help that significantly. Like an MRI. Chelsea Berghorn to everyone. Do you ever recommend prolotherapy injections for patients with craniocervical instability that was diagnosed after Chiari decompression surgery to avoid having another surgery? I've not any experience with prolotherapy injections, so I guess I can't really comment on that. You know, things that I try to do if you're concerned about hypermobility or weakened neck musculature, is trying to shrink the neck muscles as much as possible. One thing is that you could use a cervical collar beforehand that could help decrease spasms, that could help decrease the pain, and then you strengthen the neck muscles up. This is a very similar strategy that used for a lot of other joints that have instability. Rotator cuff is very similar. As people get older, rotator cuff muscles, they may tear, they may get weaker. That's just common. They'll get pain, and the goal is rest. Okay. It's easy to rest the rotator cuff. You can just not use it as much. You can put a sling, and then the goal after that is then to strengthen the muscles. There's all different exercises to do. The same thing for the neck. If you get neck pain, you can rest it. Hard to rest your neck, but the only way to do is put yourself in a cervical collar. Pain goes away, spasms go away. Then you strengthen the neck muscles by doing strengthening exercises or physical therapy. But I don't have any experience with prolotherapy, so you have to ask another expert on that. Kristen Emsley, oh yeah, back on the thoracic syrinx from Kristen. She said 2 car wrecks in 3 years. Pain management keeps burning nerves and epidurals for compression symptoms. Keeps burning nerves. Well, yeah, I would definitely see probably see a neurosurgeon and just see, hey, what's the syrinx from? Sometimes these are, depends. Sometimes they're very small and you're not going to be able to, they're not going to be able to drain the actual syrinx or the damage already done from the syrinx. So those are questions that neurosurgeon could better answer. All right, Jennifer, thank you so much. Okay, thank you, Jennifer. Sean O'Donnell says, can a non-specialist in Chiari or Syringomyelia neurosurgeon diagnose an idiopathic syrinx incorrectly? Also, any thoughts on stem cells for syrinx? I have no experience with stem cells for syrinx. I don't know anything in the literature that suggests that would work. So I could tell you that. Nothing that's published. So no kind of peer-reviewed study suggests that. And so that's peer-reviewed means that other neurosurgeons, other physicians would agree with it. But there may be something out there that I don't know. And just haven't seen the literature. Can a non-specialist in Chiari diagnose an idiopathic syrinx incorrectly? It's possible, okay, for sure. Sometimes the syrinx can be difficult, so that needs to be worked up correctly. If you're still questioning whether your syrinx is idiopathic or for something else, or what the cause is, then yeah, getting a second opinion might be a good idea. And the stem cells, you bring the literature to the physician, say what you, or whatever information you have on it, and see what they think, and maybe they, haven't seen it before, or something that's very brand new that's just come out. That could be also important to do. So they would, they could look into it themselves. Nicole Hills, I'm being treated by a neurologist and have only a brain MRI. Should I be seeing a neurosurgeon? If you have Chiari malformation, you should be seen by a neurosurgeon, maybe someone that specializes in Chiari. If you can find someone or that's easily accessible to you, that would be a good idea. Back to weary again. My syrinx dissolved after the shunt placement. Idiopathic due to changed diet and nutrition, mindfulness, and now I'm diagnosed with stiff person syndrome last year. Have you ever encountered this two occurring sequentially? I have not actually. So that would be your case would be very rare and very unique. Yeah, weary. Okay. So hopefully things improve for you and you're getting the best care you can, and I'm glad you focus on diet and nutrition, mindfulness. Those are extremely important. But I'm sorry I can't offer you more advice and such. All right, Rachel says, I had a decompression 20 years ago and now I have a cervical hernia, herniation and radiculopathy, probably at C6. It seems syrinx enlarging. Do you think this could be related to the herniation? It can be. I've seen that. And it can be just from like obstruction again of CSF flow from the herniation, and so then you can get enlarging syrinx. And you may just be a potential risk of you have that potential central canal there from maybe from the Chiari or your the syrinx before, and that's how it developed. And now you have this herniation that's leading to more of a risk of getting a larger syrinx because of that. So it can be. Is there known? So Susan Edwards says, is there known connection between a Chiari and dystonia or super tight cramped muscles? Was the likely reason? Was the outcome? Well, the only thing with Chiari that I've seen with dystonia or like tight cramped muscles or spasticity, usually someone with the syrinx is very large and the syrinx have been there a long time. They'll get spasticity, and then eventually they'll get muscle weakness. They'll get atrophy of their muscles. You see it in the hands. Um, and they'll get inability to open and close the hands. But that needs imaging, MRIs, see a neurosurgeon expert in Chiari. And hopefully then you treat that soon enough, you can prevent it from getting worse, right? Because once muscle atrophy occurs, that's hard. There's been damage then done to the spinal cord, so we want to do surgery before that happens. Do you recommend another decompression surgery if symptoms returns? So it all depends, right? That's a great question. It seems like that's a common question. It just depends on what the imaging looks like, right? If it looks like there's a lot of room for the cerebellum and there's CSF around the cerebellum, and there's not brainstem compression, and looks like there's good CSF flow, maybe that's not the answer. Maybe there's other things that are the problem. Maybe you have instability. There could be other things. Maybe their symptoms are not from Chiari at all. Maybe it's from other types of headaches, or it just depends, or some other condition. It just depends, I guess. Imaging is probably critical. Good history, physical exam is critical, and then talking with a Chiari expert and neurosurgeon. Kristen Emsley, would a thoracic syrinx cause compression? Well, it depends on the syrinx. Sometimes if it's an enlarging syrinx, it will cause the spinal cord to enlarge. Those kind of cases, if there's some kind of there's a cause for it, then and causing symptoms, then it may need treatment. Let's see, Kristen says, can a thoracic syrinx cause chronic neck pain? I guess it depends on how high the syrinx goes up, but if it goes up high enough to the bottom of the cervical spine, then yes, it can cause neck pain. Adam, Verena, do you recommend O to C2 fusion if I have a CCI diagnosis from a neurosurgeon? 137 degree CXA, and there's a lot of different changes, different degrees that he writes down here in terms of rotation of the neck and such. The CXA, when he's talking about that as the angle of the clivus and the cervical spine. And it just depends what your imaging looks like and if you have really bony abnormalities or not. That's really the key that I look at. There are a lot of patients that have abnormal CXAs that are much less than that. They're 120, 115, and they're fine, right? 137 is getting to the point that's pretty normal. So it just depends on what your imaging looks like, your MRI or X-rays or CT scan and such, and going from there to make sure that that's the right diagnosis. Because you don't want to have a surgery and a fusion, and then still have symptoms afterwards and find out, oh yeah, it was from something else, right? So all depends what your neurosurgeon thinks and what the imaging looks like, and go on from there. Is it common to find diffuse, so idiopathic skeletal hyperostosis in Chiari patients? Dish. No, that's not common. It is, but I've not seen that. But dish is where a lot of bone forms along the cervical spine. I've seen a lot of other abnormalities though with Chiari. Chiari is common, 2 to 4% of the population, like I mentioned. So you're going to see other conditions that associate with Chiari that may be totally unrelated, but it can complicate the picture, right? So. Not common. That'd be rare, very unique. Hopefully that you get treatment, Rachel, and you get your symptoms treated and things improve for you. Try to get through all the questions, or go rapid fire there. Hopefully everyone gets their sees a specialist and they get their proper treatment they need to, and they have a supportive environment. That's very important. again, if there's any questions, you can always ask us or reach out to ASAP.
Thank you, Brian. Appreciate the time and effort you've put into this, and we're looking forward to seeing you in Iowa in July.
Perfect.
Folks, get registered, and we'll see you there as well. Thank you,
Thanks,
everybody.
guys.
Have a great night.